Ulcerative colitis. It is made up of two words. Ulcerative, which means presence of ulcer, and colitis, made up of col, which means colon, and itis, inflammation. We are going to talk about inflammatory bowel disease. Inflammatory bowel disease is of three types: ulcerative colitis, Crohn's disease, and intermediate type. Intermediate type is when we cannot distinguish between ulcerative colitis and Crohn's disease. Ulcerative colitis. It is made up of two words. Ulcerative, which means presence of ulcer, and colitis, made up of col, which means colon, and itis, inflammation of colon. Ulcerative colitis is a mucosal process, which means it involves only the mucosa and submucosa of colon, and not the muscularis layer. Ulcerative colitis involve only the rectum and colon. Crohn's disease, in contrast to UC, is a transmural inflammatory process, which may involve any part of the GI tract. Endoscopically, the mucosa has multiple inflammatory pseudopolyps. In long-standing ulcerative colitis, the colon may be foreshortened, and the mucosa replaced by scar. Ulcerative colitis does not involve the small intestine, but the terminal ileum may demonstrate inflammatory changes. This is called backwash ileitis. A key feature of ulcerative colitis is the continuous involvement of the rectum and colon. Because the inflammation in ulcerative colitis is purely mucosal, strictures are highly uncommon. We can see here that ulcerative colitis is continuous, starting from the rectum extending proximally. In Crohn's disease, we can see skip lesions. Now moving on to pathology. Ulcerative colitis involve the mucosa and submucosa of the colon, with sparing of the muscularis. Typical gross appearance: hyperemic mucosa. Rectal involvement. Proctitis is the hallmark of the disease, and the diagnosis should be seriously questioned if the rectal mucosa is not affected. Pseudopolyps, seen in ulcerative colitis. Most characteristic lesion of ulcerative colitis: crypt abscess, which are collections of neutrophils, which fill and expand the lumina of individual crypts of Leberkuchen. Crypt abscesses are not specific for ulcerative colitis, and can be seen in Crohn's disease and infectious colitis. Diagnostics. Characteristic of ulcerative colitis is continuous uninterrupted inflammation of the colonic mucosa, beginning in the distal rectum and extending proximally. Moving on to the clinical features. Age. There is bimodal distribution involving 3rd and 7th decade. Male-female ratio is equal. Symptoms include bloody diarrhea and crampy abdominal pain. Proctitis may produce tenesmus. Severe abdominal pain raise the concern of fulminant colitis or toxic megacolon. Now we are going to make our diagnosis. We will do colonoscopy and mucosal biopsy. Evaluation with colonoscopy or barium enema during an acute flare is contraindicated because of the risk of perforation. Barium enema is less sensitive than colonoscopy and may not detect early disease. In long-standing ulcerative colitis, lead pipe appearance is seen. In lead pipe colon, the colon is foreshortened and lacks haustral markings. Serologic markers includes ASCA anti-Saccharomyces cerevisiae and PANCA paranuclear antineutrophil cytoplasmic antibody. ASCA positive, PANCA negative is associated with a diagnosis of Crohn's disease. ASCA negative PANCA positive correlates with ulcerative colitis. Now we talk about treatment. We can either give conservative management or surgical treatment. Surgery can be emergency surgery or elective surgery. Indications of emergency surgery are proven or suspected case of perforation, massive hemorrhage. Toxic megacolon, fulminant colitis. Indication of elective surgery, intractable disease, dysplastic changes, cancer, chronic ulcerative colitis of more than 10 years. Emergency operative procedures. In a patient with fulminant colitis and megacolon, total abdominal colectomy with endoilostomy rather than total proctocolectomy is done. Although the rectum is invariably diseased, most patients improve dramatically after an abdominal colectomy, and this operation avoids a difficult and time-consuming pelvic dissection in a critically ill patient. Rarely a loop ileostomy and decompressing colostomy may be done if the patient is too unstable to withstand colectomy. Massive hemorrhage that includes bleeding from rectum is managed by proctectomy, and either an ileostomy or ileal pouch anal anastomosis. Elective operative procedures. 1. Restorative proctocolectomy, ileal pouch anal anastomosis. That is the procedure choice. In this procedure the entire colon and rectum are excised, and the ile made into reservoir or pouch. Total proctocolectomy and ileostomy has been the gold standard for patients with chronic ulcerative colitis. Total proctocolectomy with continent ileostomy pouch.